You can start your session, Dr. Prashant.
Good evening, doctors.
Good evening, Dr.
Welcome to this webinar on the role of Oseltamivir in flu management. This webinar, as you know, is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in our portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally, and we are amongst the largest closely held pharmaceutical company in India. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and Hetero Healthcare is Asia's largest API manufacturing facility at ACZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered to the patient Oseltamivir, favipiravir, and remdesivir, because of which in August 2020, they received an award of Pharma Excellence for COVID drugs. Today's webinar, Role of Oseltamivir in Flu Management, we have got Dr. Pramod Zog sir as our moderator. Welcome, Dr. Zog sir. Then we have got Dr. Anil MU and Dr. Somashekar as our speaker. Welcome, Dr. Anil. Welcome, Dr. Somashekar. Dr. Pramod Zog sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI CSO 2016 to 19, Chairman Mini Recipe Module of IIP, author of book Cophology. Once again, welcome, Dr. Zog. Professor Dr. Somashekar AR sir is Professor Ramaya Medical College, Pediatric Pulmonologist and Adolescent Care Specialist, President IIP State Respiratory Chapter 2015-16, Treasurer IIP Allergy Chapter 2015, IIP State Allergy Chapter, Joint Secretary IIP Bangalore 2016, Secretary AHA 2016-17, EB Central IIP Respiratory Chapter, EB Central IIP 2015-2017, Secretary IIP State Allergy Chapter 2021, Chief Editor Pulmoscan, Executive Editor Journal of Pediatric Pulmonology, EB National Respiratory Chapter 2023, Secretary Environment Chapter of Child Health Group of IIP 2023-24, President IIP Bangalore BPS 2024. Welcome, Dr. Somashekar, once again. Dr. Anil MU sir is MBBS Eminent Pediatrics with Fellowship in Pediatric Critical Care and Diploma in Allergy and Asthma DAA. Dr. Anil is Lead Consultant Pediatrics and Pediatric Critical Care, Sparsh Hospital, Bengaluru. With this brief introduction, I hand over the session to Dr. Pramod Zog sir. Over to you, sir.
Thank you. Thank you. Good. Okay. So, good evening, all friends. And today we are here for some exciting discussion on influenza and management of influenza with special reference to an antiviral agent, Oseltamivir, in the management of influenza. And for this, I have two influencers with me, Dr. Somashekar and Dr. Anil, with the 2016 presidential strain of IAP. Indian Academy of Pediatrics says, every year new people coming up in the management, and every year, that's why I say the strain is different. And you can see that the nomenclature of Dr. Jog has been written in the style of influenza, which depicts the place of origin and the year of origin and so on and so forth. So in many parts of our country, monsoon is in full swing, and respiratory illnesses like RSV in children, particularly under the age of 1 year, and influenza, they are in full swing. And dengue, the mosquito-borne illness, is also seen to a great extent. And monsoon is the season when influenza is at its peak. Though in India, it is, a disease with year-round transmission, particularly in the areas of Kashmir and Tamil Nadu. The influenza illness is seen more towards the end of the year, while other parts of our country, there is, activity of this illness during monsoon and immediately after the monsoon. And I remember the days when, people were not much worried when one used to say that, the illness is viral. And recently I had one small little child who came with a doll in the hand. And when, I was just telling the parents not to worry, this is viral, the girl also was saying and telling her doll, oh, don't worry, it's viral, it's viral. So people in general have, a connotation about this viral illness that, they are self-limiting and there is nothing to worry about. But over the last few years, this particular, feeling in the mind, I think there is a need to reconsider, because illnesses like COVID and illnesses like, the pandemic influenza have given a big blow. And, the cytokine storms which are associated with some of these viruses, they always create a big panic in our mind. So the question is whether the incidence of viral infections has increased. The answer is obviously yes, because the bacterial illnesses have vaccines. Viral illnesses, majority of them, which are respiratory viral illnesses, they don't have vaccine except for influenza, where the efficacy of the vaccine is only to the tune of 60 or 70%. RSV doesn't have a vaccine, and rhino and adeno and all those respiratory viruses, they don't have any vaccine. And that's why the incidence of viral infections is increasing. And also there is, something like immune debt, where during COVID, children and adults, they did not develop adequate immunity against some of these viruses. And that's why in our OPDs, we are able to see so many recurrent respiratory infections. Though all of us are aware that about 8 to 10 respiratory infections of viral nature are normal in a normally growing child. And as I said, we have seen waves of different viruses making their presence after COVID, particularly like the hand, foot, mouth disease, sometimes this RSV, sometimes adenovirus. And I remember in the areas where measles immunization was on the lower side, measles also was seen to a great extent. And not only the younger children, but also the older ones were getting affected. And recently I came across a small little child, 3-year-old, with fever, cold, and cough, who progressed to breathlessness and diagnosed as ARDS and admitted to the PICU, ventilated, and was treated with Oseltamivir supportive management, and turned out to have H3N2. He was ventilated for 3 days and then he was all right. Of course, this particular case, it raised a lot of queries in my institute, where everyone was asking that in a previously healthy child coming with cough, cold, and fever and progressing rapidly to an illness like ARDS, whether we should consider giving oseltamivir to every child coming with cough, cold, and fever. And of course, we are going to discuss some of these issues, and we will be clearer at the end of this symposium. And some of our confusing points, these are the confusing points about flu, like whether, when a child comes with respiratory infection, particularly whether it is bacterial or viral, if the infection is likely to be viral, whether it is rhinovirus, adenovirus, influenza, or parainfluenza. If it is influenza, what is the type? And then whether one should start oseltamivir upfront to play safe. So the healthcare related challenges in monsoon are many, and the mortality and the morbidity related to influenza is increasing. One must be aware of the KYC, just as in the banks we have your KYC, know your customer. This our influenza KYC is also very important. It's a naughty virus. Why naughty? Because it's an RNA virus. All RNA viruses are very naughty. COVID, this influenza, then RSV, all those, they will change their structures and they will behave differently. Influenza A is the one which produces frequent epidemics, because there are minor antigenic variations in the glycoproteins H and N, which are present on the outer side of this virus, and it produces periodic pandemics. As we know, there have been 4 major pandemics, about which I will tell you in a minute. And then influenza B is the one which infects only humans and produces local epidemics. It doesn't infect animals. See, when the influenza virus from the birds and influenza virus from the human beings together mix up in some other third animal like a pig, then the pig acts as a mixing vessel where a totally new virus comes in existence, like H1N1 pandemic virus came in 2009. And that's why influenza A is the one which has always produced a lot of problems. And then, as I was trying to tell you, the outer glycoproteins of influenza virus are hemagglutinin and neuraminidase. Hemagglutinin is the one which is useful for this virus to get attachment to the respiratory epithelial cell. Once the virus gets attached with the help of this particular hemagglutinin, the RNA of the virus enters into the respiratory epithelial cell. The RNAs, they replicate and they are ready to get out of this particular respiratory epithelial cell, where all these viruses are separated, the virions are separated with the help of neuraminidase. That's why it's called the molecular seizures. And oseltamivir, the neuraminidase inhibitor, is the one which exactly acts at this point and prevents the release of these virions, so that the infection of the other respiratory epithelial cells is prevented. And as I was trying to tell you, there were 4 major global pandemics. The one in 1919, which involved almost 1/3 of the global population. And at that time, oseltamivir, antivirals, of course, were not existent. The only treatment was bed rest and fluids and oxygen to some extent. And that's why the mortality at that time was very high. Then 1957, 1968, and 2009 were the major global pandemics. And that's why it is essential to know the epidemiology of the circulating strains of the influenza viruses. And Dr. Anil, if you have some information related to this aspect, would you please like to share with the audience?
Yes, sir. Thank you very much. So the WHO, what it does is it has a standing committee which meets twice a year, and they'll release the recent position statement after going through all the surveillance data in the world available. They release this data. So the whatever is the latest, that is what is it saying is that uh, currently the pandemic that we are going through in the whole world, influenza A is being detected much more than the influenza B. And again, if you look at the influenza A subtypes, we have the H1N1, that is the maximum which is being reported. The second one is the H3N2. But unfortunately, right now, the strain which is going around probably in India, like in Bangalore, we are getting lots of H3N2, very less of H1N1. H1N1 we are getting, but it is less. But globally, when we look at it, H1N1 is more than the H3N2 subtype. Where coming to influenza B is much lesser. Earlier, like we know, the flu vaccine contains influenza A, that is H1N1, H3N2, and in influenza B, it contains the subtypes of Victoria and Yamagata. So after September 2020, the Yamagata strain has not been found anywhere. It's only the Victoria lineage which has been found among the influenza B viruses. So probably going ahead in future, our flu vaccines will contain only 3 subtypes. That will be the influenza A, H1N1, H3N2, and the Victoria lineage. Yamagata will be dropped. So this is the current epidemiology that is going on among the flu viruses.
Yeah. Thank you very much. And just for the information of our listeners, all those viruses H1N1, H3N2, those the numbers like 1, 2, and 3, they are earlier numbers, and the ones which are non-human like H5N9 and the other numbers, they usually affect the birds or the other animals. So that's only for the information of our listeners.
Those
And
are the
then,
pandemic kind of viruses are the ones which
yeah,
are starting with H5, H9. These are the ones which cause pandemics. The seasonal flu which have been there throughout the year have been H1N1 and H3N2.
right.
Yes, sir.
Now, this flu virus spreads to others up to about 6 feet, and these viruses are spread mainly by the droplets. And these droplets can land in the mouth or the nose of the people who are nearby. And the transmission is also through fomites. When someone sneezes into the hand or into the handkerchief or touches the hands on the table, that also acts as a source of transmission. So, Dr. Somashekar, in your practice, what are the different clinical scenarios with which influenza presents in the pediatric population?
Thank you, sir, and well taken by startup by Dr. Anil, as said about epidemic and the present scenario that we know the packets of epidemic is going on. But majority they are coming with whatever the is a OPD practice. It is a more of fever, cough, cold, sore throat, rhinorrhea, little bit of body ache, and sometimes some GA symptom like vomiting and diarrhea. This is a common symptom. What we some little older children they may experience the severe headache. This is the common. But when it comes to what is that, why are talking about oseltamivir, these patients are also few of them going for the severe illness, influenza-like illness becoming severe, where they get admitted in the ICU or high dependence area with complication like febrile seizures are known. We have been seeing some patients, encephalopathy is known, GA severe dehydration is known, in few cases myocarditis. But in our experience, we have seen just cough and cold, 1 year baby. Today we discharge that baby, fever cold for within a day it has deteriorated and developed distress and packets of shadows on the X-ray, and the swab test was positive. And like that, one more case was like just detected case of nephrotic syndrome. By next day, it was in shock, severe distress. So see, these are all the condition where the comorbid condition the children's will deteriorate. So those things should be addressed. Diabetes, obesity, asthmatic patients are immunocompromised. So what I was saying is one packet majority is a self-limiting condition that is seen in over OPD, fever, cough, cold, other GA symptom. Other thing is little complicated, like febrile encephalopathy or febrile seizure or other, or more cell, like in a specific condition or a comorbid condition, like immunocompromised state, like diabetes, obesity, asthmatic, all those things. I'm sure these are the common experience we are undergoing. I think Dr. Anil, being from the intensive background, maybe he has got fewer one or two case scenarios of.
Yeah, sure.
Ye-
Dr. Anil, you can just elaborate more on the
Yes, sir. Majority are the respiratory kind we are getting right now. Probably very few of them are landing up in the ICU requiring little bit of respiratory support, and few of them progressive cases are landing with CNS complications. CNS complications, majority like sir told, has been like high because of the high grade fever. They're throwing febrile seizures, and few of them are landing with encephalopathy, like the blanket diagnosis of acute febrile encephalopathy, which is managed. And in such situation, in this epidemic going on, we should have Oseltamivir is as one of the blanket treatments for these children who are presenting with acute febrile encephalopathy.
Okay, that's great. And basically, the differentiation between different respiratory viruses is not very simple. Some of these manifestations are common to these viruses. One should be aware that is a broad term like influenza-like illness which has been used, but H1N1 influenza is the father of all those influenza-like illnesses because it produces systemic symptoms, a headache, body ache, weakness, high fever in the beginning. So all these are not seen in viruses like rhinovirus and all, which affect only the nose or the localized infection takes place. So it is important that we are aware of this particular fact because we see quite often even children aged 8 or 9 or 10 years are lifted and brought to the OPD by their parents, with influenza. And Dr. Anil, maybe you could also inform our audience about the emergency warning signs of flu, which parents should be aware of.
Yes, sir. These red flag signs, I think we should be very much aware and also educate the parents. When we are seeing very mild cases of flu on day 1, day 2, we should educate the parents also on these red flag signs. First and foremost, like sir told, it's an acute febrile illness and the child becomes very tired. How is the child behaving in the interfebrile period is very, very important. If the child is becoming active, playful, and accepting feeds, we all know that there are no danger signs and safely this child can be managed on OPD basis. If at all the child is becoming lethargic, child is having difficulty to accept feeds, inability to drink, or the child starts developing respiratory problems like fast breathing is there, or the cough becomes incessant cough, or child becomes irritable, drowsy. All these are the red flags that we look at. So being unable to feed, any breathing issues, I think these are the ones which the parent has to look forward to.
Very good. So now the point is that the complications of flu, all of them could be, rather put in a alphabet A, where it could be acute respiratory infection, like about 25% children with influenza can get secondarily complicated with Streptococcus pneumoniae or Staphylococcus. As we saw in the first case, some of them can get complicated into ARDS. Some of them can go into acute otitis media, and all these illnesses they will produce absenteeism from the school, and the treating physician many times gets confused as to whether this is bacterial or viral, and that's why there is a lot of antibiotic abuse. We will just come to the treatment of influenza, and Dr. Somashekar, we are all aware that there are some categories of management of influenza. So, would you just elaborate a bit about the management of influenza?
See, category A is just a suspected case where it may be viral or bacterial. Just differentiate based on the symptoms. It's usually uncomplicated. Patients will have mild fever, cough. Just like behave like any other viral illness. Sometimes they have diarrhea or vomiting. Category B is the where high risk or severe symptoms. There here includes the high grade fever, the persistent fever, severe throat pain will be there with additional category A symptoms like diarrhea, vomiting, extra respiratory symptoms. And here this is the area where they require little of home isolation, and that is the time you can think of starting Oseltamivir with based on your swab studies. And it also includes the category B, also includes the symptom already I mentioned. But this is one more category in this few points are added, that is high risk condition. Taken less than 5 years and less than 2 years are the and pregnant women and children extreme ages like 65. They are the one suspected case that they are included in high risk or the severe symptom that comes to category B. Along with that, if they got chronic lung diseases, kidney, blood, any long-standing diabetes, uncontrolled diabetes, neurological disorder, progressive neurological disorder, cancers, or retroviral diseases, immunocompromised, these are all conditions. Our patients on long-term steroids, they are all included as category B. Category C includes patients with category A and B symptom, both are included here, and who also exhibits acute symptoms like severe breathlessness, chest pain, drowsiness, hypotension, and bloody sputum. They're all included in, and mainly taken as difficulty in breathing, low saturation. There are the concern of category C. What I meant to say, category is mild, maybe like any other illness. Category B with the high risk condition or with a comorbid condition, extreme ages like less than 5 years, less than 2 years, more than 65 years, uncontrolled diabetes, or the immunocompromised. Category C is the where acute symptoms start, like breathlessness, hypotension, low blood pressure, blood is put on, then you consider them as category C.
Yeah, that's very good. And basically, this categorization is of great help, particularly when one is, in two minds whether one should send the throat swab or whether one should start with the antiviral agents. Because as we will see in the subsequent discussion, these two decisions are very important in the management of influenza. Before we proceed to that particular point, I will just tell a few points about the antiviral drugs. And as I was trying to tell you in the earlier part, the neuraminidase inhibitors like oseltamivir are the ones which block the viral neuraminidase enzyme, and that is very critical in releasing the virions from the infected host cells. And these drugs are active against influenza A and influenza B. And oseltamivir is a potent and a selective inhibitor of the neuraminidase enzyme, and it's a prodrug. It is converted to the active form oseltamivir carboxylate in the liver, and it inhibits the virus replication and prevents further spread of infection. And this is a diagrammatic representation as to how the release of new virions is blocked by oseltamivir. It is important to note that neuraminidase is an enzyme which is very specific for influenza, and that is why oseltamivir should be used in only those cases where you strongly suspect influenza. It's not a medication to be used for all viruses. Otherwise, we will, land up in development of resistance against even this molecule. So one has to be very careful because it's a very, very specific enzyme for influenza virus. Okay. And that's why if a child is under the age of 1 year, where you are in two minds, whether it is RSV or influenza, and if you are at a place where you can afford doing the throat swab, it's prudent and wise to rule out, other viral infections so that the abuse of this molecule is not there. And then this particular molecule was the first oral neuraminidase inhibitor, and it is approved in more than 100 countries. And CDC and American Academy of Pediatrics have approved this molecule. So we have just seen the categories of treatment, and this is the summary of the treatment guidelines. So, Dr. Anil, would you like to elaborate a bit on this aspect?
Yes, sir. Category A are the kinds that we see in the OPD, which are self-limiting viral illness. Child is active in between playful. So in such situations, we usually need not test them nor treat them with specific antivirals if they're active, playful, and all that. So home isolation general supportive care of taking plenty of liquids, paracetamol, and rest at home and home isolation is sufficient. Category B are the moderately sick ones or the ones who have other coexisting comorbidities. In such situations, I think this is where the role of oseltamivir comes in. We will have to go ahead and start them on oseltamivir even empirically. And again, in category B, only the ones who are sick enough to get admitted, yes, we go ahead and test them with a swab to know epidemiologically what is happening and to take a call on the oseltamivir therapy. We do that. And category C are the more sicker ones who end up in the HDO or in the ICU, where I think universally we are going ahead and testing them just to be sure of the diagnosis that we are not missing anything else. So the testing is also very much required, and also empirical therapy with oseltamivir is required in category C.
And I'm sure that our audience knows that the use of aspirin as an antipyretic is to be avoided in children with influenza. That's because of the possibility of development of Rye syndrome, which was so very common. I remember when we were residents, we used to get this condition very often. And children with influenza who receive aspirin, they land up in some of these complications where there is something akin to the liver failure. And this is the dosage and the recommendation regime for oseltamivir, where adults receive 75 milligrams of this molecule twice daily as a part of therapy and 75 milligrams once daily as a part of chemoprophylaxis. The therapy is for 5 days, the chemoprophylaxis is for 10 days. Of course, some physicians, they give this particular therapy a little longer for therapy, and some of them I have seen even use little more dose of this particular molecule. However, in pediatric practice, we should restrict ourselves to the therapy for 5 days and chemoprophylaxis for 10 days. And depending on the weight band, children receive anywhere between 60 milligrams per day up to 150 milligrams per day, and infants under the age of 1 year receive 3 milligrams per kg twice daily. And these infants, they are not the ones where chemoprophylaxis is advocated. Dr. Somashekar, how does early initiation of oseltamivir influence the clinical outcome related to the duration of illness and progression to severe disease and complications, etc.?
See, as per our practice, as well as the evidence, as per the guidelines, better to start within 24 to 48 hours. That's the for the best outcome. When you're suspecting, or as Dr. Anil was saying, high index of suspicion or any exposure is there, you just start early, especially in a high dependence area, start 24 to 48 hours. But the question, sometimes we'll have dilemma whether it's a bacterial, viral, or we'll wait and see policy, or we'll be waiting for the other symptoms to develop. That is the time, even at a days of 4 or 5, you can start, because you can give the total benefit if you're strongly suspecting a case of the H1N1. The question is, early starting makes the best outcome of the diseases.
Right. And Dr. Anil, now that you are in the ICU, what is your experience about starting oseltamivir even little later on day 4 or 5 when a child comes in a bit of a serious state to the ICU?
Yes, sir. For anybody who is sick, that is category B and category C, it is never too late to think about flu and to start. Just because it is day 4 on day 5, we don't withhold the medicine, because what happens, oseltamivir, as like you told, the mechanism is it spreads the spread of the virions within the body. So if it's already a severe disease, that means the virion load is very high on the body. If we don't use it even on day 4, day 5, only the load will increase. I think even if it is day 4 or day 5, for anybody who is sick enough to get admitted, we should start. Even if it is late, we should start.
Like it reduces the further complication as well as
Sir.
the viral shedding.
Right, sir.
Right. So thank you for that. So
mean duration of stay will come down. Mean duration of stay.
Right. And even in Pune, we had in an institute similar study during COVID times, where all these facts were proved beyond doubt with the help of a large clinical trial. Anyway, the empiric and the early use of oseltamivir has been substantiated by many clinical trials, wherein the antibiotic use, the influenza-related low respiratory tract complications and hospitalization were all, rather impacted by early use of oseltamivir. And even in adults, basically the advantages were seen. And only to reiterate this particular aspect, Dr. Somashekar, will you like to tell the audience whether one should start empirically or whether one should start oseltamivir after investigations?
Ideally, start because we are worried about resistance. Ideally, you start after the investigation. But you have a strong suspicion, high index of suspicion, progressive diseases start empirically. Or if a child is suffering less than 2 years exposed to all the, take it as a high index of suspicion. Or whole family post exposure also you can start. But always, even though said that extreme ages or post exposure, if there is a strong possibility of infection, you can start empirically. Ideally, it is after the investigation is much better.
Some of these guideline recommendations, from WHO, they say that empiric therapy is strongly recommended and treatment should be started as soon as possible. And the laboratory confirmation of this influenza virus infection is not necessary for initiation of therapy. And negative laboratory test of H1N1 does not exclude the diagnosis. And that's why it is recommended that you start it early. And let us see some cases like, this child who came for fever for 3 days with cold and cough, and he was on metered dose inhaler since 4 months, well controlled. And he received symptomatic therapy. And after 3 days, he again came back with similar complaints. And during these 3 days, of course, he was better and active in between. Now, the common problem is, these are the, parents who always come to us, and this particular situation is very common in our practice. So these are recurrent viral upper respiratory infections which have become very frequent. They occur at a shorter interval. So the problem is, counseling the parents, because they come to you with an expectation that the child would recover, and many of them feel that he will never get cough and cold in the lifetime again. Of course, that is something, the parental psychology. So Dr. Anil, if such a situation is confronted by you, how would you counsel these parents?
Yes, sir. This is, I think, for all of us pediatricians, this is a very, very common scenario in your OPD practice. Probably every other patient will be doing this. Since this is an active child and recurrent, we always counsel them, telling that the child is doing fine. We look at the growth charts. We'll tell them that there are no red flags in the child's growth. Child is growing fine. And especially in this age group, we do see, especially when we have a school-going elder child may be there, or this child himself or herself may be going to the preschool nursery, because they start pretty early these days. Even in the second year, their kids are being sent to pre-toddler. I had heard toddler. Now I heard a term pre-toddler classes, which is in the second year itself. They are spending 1 or 2 hours in the daycare or the nursery or in the schools. So it's very common for them to pick up all these other viruses from the other children. So, and this is how, as a child is growing, the immunity is also growing. So we spend couple of those extra minutes and counsel them. This is very much a normal to have 8 to 10 episodes of upper respiratory infections in a year. We'll auscultate the lung and reconfirm that the lung is very clear, child is fine, and little bit of cold, cough or fever. We will see, we will revisit in 2-3 days. And if required, we will, if they're very concerned about antibiotics, we'll tell them, please come back to me in the next 48 hours. We'll see how it goes and we'll take it from there.
Very well said. And then I always tell them, these recurrent viral respiratory infections are a part of growing. And I always tell them, let him grow with the growth chart. Okay. So that's something, is quite convincing, because if I show them the growth chart and the child, growing very nicely, then they usually do not pressurize us to, prescribe
Or
antibiotics.
else we can always tell them common cold is one more member of your family. There are not 4 of you at home, there are 5 of you at home. They'll ask who is the 5th one. Common cold is the 5th one. As long as the child grows up, common cold may be the 5th member of your family. Please adjust and stay with the 5th member.
Okay. Yeah, that's a good one. I think I will start telling that
Done
now.
is in the hospital, we put a small sticker in the wards, like about antibiotics. Don't ask, dear parents, don't ask for antibiotics. And we have put 2-3 lines about what is the importance of antibiotic, when we should use. And we have mentioned not to ask for antibiotic. It is
Okay.
because we are associated with an international collaborated hospital. So we got that guidelines also.
Okay. Okay. So that's very important. And as we discussed earlier, for a child to get about 8 to 10 viral upper respiratory infections is normal in the first year of life. And of course, one should be aware of some of these clinical clues. For example, rhinovirus, as we said earlier, will produce only common cold, and the child otherwise will not be exhausted as in flu. Adenovirus will produce some different presentations like pharyngoconjunctival fever, diarrhea, mesenteric lymph node enlargement, or hemorrhagic cystitis. And RSV would, impact children under the age of 1 year. And bacteria like Streptococcus this group A beta hemolytic Streptococcus would produce fever, follicular tonsillitis, and tender cervical nodes. If it is pneumococcus, it would produce fever, grunting, and tachypnea. And staph would produce rapidly progressing, a child who is looking toxic. And mycoplasma, particularly, would be affecting the children above 5 years, predominantly presenting with cough. And in general, a child who has viral infection doesn't appear sick, but the X-ray of such a child looks more sick. While in case of bacterial infections, the child is sick and X-ray is also likely to be sick. What I wanted to say is that, this is a bit of a point which our colleagues can remember. And then this is, a 4-year-old child coming with cough, fever of high grade for 5 days, not settling with oral medication. On admission, the child has tachypnea and needs oxygen support. And this is the X-ray, which shows the involvement of the right side of the lungs. And the hemoglobin is 11.6. Total count is on the lower side. Platelet count is also on the lower side. And there is impairment of the liver functions. And nasopharyngeal aspirate is, rather the swab is positive for H3N2. And it has been diagnosed as a case of influenza with low WBC count and the low platelet count. So this scenario in the monsoon season, I would like Dr. Anil to just dissect out and analyze for the benefit of our listeners. Yeah.
Yes, sir. This is a child with acute respiratory viral kind of an illness, probably, or a respiratory kind of an illness, which started with a focus probably in the lung. And child has gotten worse over the first 5 days. And there is definitely a right-sided paracardiac patch and infiltrations. It's going on. And child has also developed tachypnea and requiring oxygen support. So it's an acute respiratory illness. And if the child is sick enough to require oxygen before, because all these reports we get only after 24 to 48 hours about the swab report. But as soon as the child comes, we take appropriate cultures, start on IV antibiotics as appropriate. And probably in this case, coamoxiclav will be the treatment when we start. And in this season, probably we would have gone ahead and started on Oseltamivir also, because we're getting lots of respiratory viral kind of illness. By the time the lab arrives, it may be few hours, couple of hours, we'll be getting the CBC tests. Again, here looking at this total counts, 1,600 platelets being on the lesser side, little bit of transaminases being elevated, again gives us a clue that this could be a viral multisystemic kind of an infection. And the swab, which may come back to us after 24 hours or so, which will confirm the diagnosis. But in the initial part, we will be covering for both bacteria as well as the viruses. And one small thing that we need to remember is about our old friend dengue, which may be still around and it can present as a coexisting infection. With the transaminases being little high and the platelets being low, it will be worthwhile, and the leukopenia, which is again a classic feature of dengue, it will be worthwhile to screen for dengue fever also in this child. It has a co-infection. Predominantly, it's a respiratory case, but we should not be forgetting in the monsoon season dengue fever.
Right. That's very important. And then, of course, this was another child who came with cough and fever for 5 days. The fever was not settling. Otherwise, the counts were normal, and the nasopharyngeal swab yielded H3N2. Another child wherein, cough, cold, and fever, the counts were normal, but the CRP was 38, and nasopharyngeal swab showed H3N2. So, Dr. Somashekar, what are the factors on which clinical response to oseltamivir depend? And we have already discussed some points related to this question, but you may repeat in case some other points are there.
See, in OPD practice, what we mentioned was patient with common coryza, cold cough. That's okay. They'll have self-limiting by 3 to 4 days. They will come. By third day, if there is a progressive tail symptom, as Dr. Anil said, if they become tired, they cannot dispose to the illness, or vomiting, diarrhea, dehydration, uncontrolled fever, severe throat, or extreme ages like less than 2 years, more than 65 years, or immunocompromised, that is the time you should start with the oseltamivir at the OPD patient. At the inpatient, as we said, progressive illness, especially respiratory. If you are saying that respiratory symptoms are deteriorating, progressive respiratory distress, tachypnea, desaturation, all those things makes you can send for the swab. Meantime, you can have empirical. This is where you can use the or overuse the oseltamivir. You can just start the medication within 24 to 48 hours. As Anil said, even at the age of 4 to 5 days, also give the benefit of doubt, because there is a very good research says that even it helps in the reducing the viral shedding and also replications. So give the benefit even if if the patient is 4 to 5 days later also, if you think the progressive illness is there, then you can start. So these are all the clinical indicators as well as more than the lab indicators, clinical indicators to start the oseltamivir.
Yes. And this, of course, was the child who deceived us. He came with cough and cold for 5 days with a high WBC count and a high CRP of 136 with a continuous high-grade fever, and the nasopharyngeal swab turned out to be positive for adenovirus. This is another girl, 5-year-old, with high fever for 5 days and cough and cold for 5 days, sick looking, with mild wheeze, but no crepitations. And the question is, whether one should put such a child on antibiotic therapy. So, Dr. Anil, what is your opinion?
Yes, sir. I think as pediatricians, it's drilled into our head about the antimicrobial stewardship. IAP, I think, is doing a great job at it. And all of us are very much for antimicrobial stewardship, and we try to avoid antibiotic as much as possible. Let's analyze the situation. It's a 5-year-old child, already 5 days of high fever, and the condition is worsening. Now she's become sick looking, probably having a mild wheeze. Uh, Decision has to be taken about an antibiotic here. I think the child is sick enough to deserve an antibiotic here. We take the appropriate cultures. Yesterday only we attended the National Conference on Infectious Diseases. The message is always take cultures before you start antibiotics. So we take the appropriate cultures, antibiotic is started, and in this season probably antivirals are also started because it's a respiratory focus. And because we know that usually around 10% of these, even though if it's a viral illness, proven viral illness is proven by a swab, 10% can have a coexisting bacterial infection. And if things are getting worse, we should not be missing out. So we can always de-escalate. If someone is sick, we start an antibiotic, but within the 48 hours, if cultures are negative, things are improving, we get our lab parameters back, which is also supporting, we can always de-escalate. And if we get a swab result positive, we may be even having confidence enough to even to stop the IV antibiotic. But once child is sick, we need to go ahead and start on antibiotics.
Right. So this child was put on amoxiclav. The WBC count was 2800, and the neutrophils were 10, lymphocytes 70. CRP was 34.7, and this child was put on oseltamivir, and the nasopharyngeal swab showed rhinovirus positivity. So we are all aware that many times we get these viruses which may be apparently innocuous, and so I would just like your opinion, Dr. Anil, about the sensitivity of these tests which are done to diagnose the type of virus, and whether you take your treatment decisions depending on those reports. So, what is your opinion in general about it?
Yes, sir. The sensitivity and specificity are pretty high. The latest generation of PCRs that is being done, the sensitivity, that is percentage where we rule in the disease, that if it is positive, that if it is influenza, we pick it up in the swab. It is pretty high. If it is a well-taken swab, we are taking a good deep nasal swab or a pharyngeal secretions, the sensitivity is as high as 95% we are able to pick up. Only in cases where it is too anteriorly taken, if it is not taken very well, then it may drop down to up to 60% detection rate. Whereas to negatively to rule out also, the specificity is as high as close to 100% is what is being told. In fact, the CDC or the WHO tells us if the swab test comes back as negative, you can even go ahead and stop the anti-influenza treatment. That is the oseltamivir, we can stop. But I think as clinicians, we should have a syndromic diagnosis which is made. And then if we don't have anything else to explain the severity of the illness, there is no other coexisting virus which is detected, it is worthwhile to continue if you have a very strong suspicion. And a virus like rhinovirus, which is usually a localized virus in the nose and doesn't cause too much systemic symptoms, we may not give too much importance because anyway it doesn't have any specific treatment. So I think the other viruses also can be picked up. And when we it's a clinical syndrome which is important as to how the child is doing clinically. That is more important. And if there is nothing else to explain the disease, we are well within our rights to continue the treatment.
Thank you. Now, this is another 7-year daughter of an IT sector parent, and the parents are very anxious because the child has had high fever for 3 days with throat irritation, and she has an examination 2 days later. The throat is mildly congested. Paracetamol has already been given. Flu and adenovirus is in the atmosphere, and right now they have come to you, Dr. Somashekar, and they want your opinion as to what should be done because they are of course from the IT sector, and I always feel that that's not only the information technology sector, but these parents are many times inquisitive and to some extent troublesome. Though some of them are very interesting because they keep us on our toes so that we are updated about our information also. But anyway, with all said and done, how would you guide them about further plan of treatment?
See, one thing is if they are known patients to you, they listen to you, whatever it is. The question is the newer ones from the IT, they have traveled, they have done the shopping, they have come to you. That is the time you have to spend a lot of time. Explain them little about this thing, the progress, the incidence, the whatever the illness duration and how the outcome, and just reassure them about the self-limiting of the disease and ask them to come for follow-up after 3 days. Tell them about the dangerous and other warning signs to be addressed. Then we tell what is the next step of treatment you are going to start, like whether you do the swab test or the blood test, or you can start antibiotics based on the clinic examination, or if it requires in the epidemic like this, we can start with the Oseltamivir. But the question is not on the day, maybe on the follow-up day, you can reassess and re-judgment can be taken to start further investigate or to start the treatment. But our assurance and our patience make all the difference.
Okay, that's very good. There's another child, 3-year-old with cough for a week and high fever for 3 days, and has crepitations and has been put on coamoxiclav, and he has been admitted for persistent fever. This child has been put on IV amoxiclav, and the parameters are almost normal, hematological parameters, but the throat swab shows influenza A, and oseltamivir has been added. Now, we already discussed a bit about antimicrobial stewardship, but then just to reiterate, when such a situation exists where we have already put a child on some antibiotic, and in the latter part of the illness, the influenza test comes positive, how should one take a decision about continuation or discontinuation of the antibiotic? Dr. Anil?
Yes, sir. I think in this situation, it's pretty clear. Labs are also supportive, and clinically, our suspicion. Without suspicion, we wouldn't have started oseltamivir nor got a swab test done. Now our clinical suspicion is being proved. I think we take it with a lot of respect and go ahead and stop the antibiotic in such a situation.
Right. So what our seniors used to say that it's an educated guess in the beginning, but it has to be an educated guess, and one should be ready to change after uh, a little while. There have been a few cases during this season, and one of these cases had influenza encephalitis. So now that you are closely associated with the intensive care settings, Dr. Anil, I think our listeners must know a bit about the neurologic complications of this illness, so that they are aware of this
Yes, sir.
information.
After respiratory system, I think the neurological system is the most commonly affected one, even though it is rare. Once in a while, we do get these cases. The most commonest ones we are getting is increased cases admissions because of febrile seizures, because of high fever in influenza, we're getting febrile seizures. And as a progression, when it is progressing, we are getting child having multiple episodes like a cluster seizures they're having because of the high grade fevers. Some of them are becoming encephalopathic. And we saw that in few cases, they went on to develop acute necrotizing encephalitis because of the progressive involvement. Because influenza, it's a multi-system involvement, and it sets out a cytokine storm kind of a situation where we see that there is an autoimmune response, or the inflammatory markers are going ahead and acting on the brain itself. Even though there is no direct invasion of the viruses into the brain, we are seeing that there are few parts, especially the thalamus, just like our JE kind of representation, where bilateral thalamus are lighting up, and few areas of necrosis also in between. We have seen that happening. Very rarely GBS has been told after 2 weeks of a febrile illness. We have seen children coming to us with weakness. Especially this is very common in influenza B. Influenza B causes severe body ache, calf pain, muscle pain, which is very characteristic of influenza B kind of a illness. This is confusing, making us getting confused with the GBS kind of a syndrome. But I think by doing a nerve conduction study, we are able to diagnose the myositis from the neuropathy, peripheral neuropathy in such situations. And of course, very rarely we are getting other system involvement of renal insufficiency or a hepatic kind of an involvement, but those cases are very, very rare.
Right, right. And of course, we have cases where, we have had influenza with RSV on different occasions. And then, these cases have, told us the plan of management, particularly where, we had to give HFNC support, and then, different aspects of management, which are relevant more to the ICU setting. And of course, as we discussed about the respiratory complications, there are also some complications related to, like toxic shock syndrome and cardiac complications like myocarditis and pericarditis. And as Dr. Anil just described, myositis, which involves bilaterally the gastrocnemius and the soleus, producing severe bilateral calf muscle pain, and hepatic complications, which we earlier discussed, like Rye syndrome in children with influenza B exposed to salicylates. Just coming to the end of today's discussion, there are some questions where we would just quickly answer some of these queries. Where Dr. Somashekar, there is a child who, is an elder sibling of 8-month-old child, and he is admitted with influenza A for LRTI, and that younger 8-month-old child now rather develops fever. Whether we should start Oseltamivir for this younger one in the family?
Looks like these are twins. Both are 8 months. Yeah, maybe one is admitted, another one is here. Yeah, I'll start this high index. I'll start with upfront for this baby. Dr. Anil?
Yes, sir. Anybody who's less than 2 years comes in that high risk zone, and we need to treat them. As soon as they're symptomatic, we need to treat. If they're not symptomatic, these are the age group where we give prophylaxis.
Right. Dr. Anil, in case if the child is not accepting the oral medicines, is there any alternative for this molecule?
Currently, the other molecules like baloxavir and all that is not available in India. Zanamivir, baloxavir is not available. So as of now, oseltamivir is the only option. We need to find some or the other way of administering the oral medicine made in smaller oligoids, or giving with other flavored agents or flavored syrups. We can, or with honey. These kind of techniques can be tried.
Right, right. And Dr. Somashekar, who are the members in the family where we need to give chemoprophylaxis?
Dr. Anil said those who got symptoms. One is that, another is extreme ages like less than 2 years or more than 65 years, and those who got uncontrolled asthma, diabetics, obese children, they should get a chemoprophylaxis. If there is anybody is exposed or being treated for the H1N1.
Right. So mainly the high risk contacts should receive the chemoprophylaxis, because in a family it's possible that this is an illness which is transmitted from a child to the adult, as opposed to COVID, where we witnessed that the illness spreads from adults to children. So here children are the culprit, and they will transmit it to the diabetic father or an asthmatic grandfather or a pregnant mother. So it is prudent to give chemoprophylaxis of 10 days to those chaps who are at a high risk. And Dr. Anil, there is a question as to whether these para-influenza viruses, whether oseltamivir works on these para-influenza viruses.
No, sir. Oseltamivir usually doesn't work on the para-influenza viruses. Para-influenza viruses we typically see in the croup kind of settings. The very small child, like less than a year or 1.5 year old, who comes with a acute croup, who will settle down with a one dose of 0.6 mg per dexa with adrenaline nebulization. These are the ones, and they don't need to be treated with oseltamivir.
So, that is something which our listeners must remember. So, what we have learned till now is that this influenza virus is a fast and a furious virus with abrupt onset, high transmissibility, rapid progression to complications like ARDS, and that's why we have to be quick in starting with oseltamivir also. And we also should remember the preventive measures like sanitization, masks, social distancing, which we learned so much during COVID times, along with the cough etiquettes and the 5 rules related to the hand,
Hello.
like hand washing, avoiding handshaking,
Hello.
using the handkerchief,
Ready?
and keeping the other persons at a hand's distance and avoiding hand touching because the transmission is also through the fomites. And of course, flu vaccination is something which is very important. All in the family, particularly the ones at a high risk, must receive this vaccine once in a year. So, along with happy birthday to you, one must say happy birthday to flu, which is very, very important. And with that, we come to the end of this interesting session wherein we have learned the ABC of influenza, which also included the types ABC and the categories ABC. And with that, I thank our colleagues, Dr.
Sir.
Somashekar and Dr. Anil, and thank Hetero Pharma for giving us an opportunity to explain certain facts related to influenza and oseltamivir. And I say namaste, and everybody, when meets somebody else, must say namaste rather than a shake hand, so that at least we will be doing our own part of keeping these transmissible illnesses away. Thank you very much. Thank you.
Thank you, sir. Pramod sir, Dr. Anil,
Thank you, sir.
Prashant
Thank you,
sir.
sir.
Thank you so much, sir. Lovely insights. Thank you. Lovely insights into both the disease as well as the disease management. I'm sure the audience has benefited out of it, especially when not to start antibiotics is a dilemma all the time. Or to start. Thanks, sir. Thanks for your time.
Thank you.
And thanks, doctor, all the doctors who took time from the schedule and attended this. Thank you, IT team Hitro. Thanks, marketing, and thanks, sales team of Hitro for super coordination. We can sign off, sir, and wish you a very pleasant evening. Thank you.
Thank you, sir. Thank you. Thank you, sir. Bye.